Dr. Farr gave a nice lecture on concussions, and I feel as the orthopedist that to try and jump on piggyback on the neurologist's advice would be a little bit foolish. So what I'm going to do is run you through kind of my common sense approach to shoulder injury in the athlete from kind of beginning of life to end of life. And I think of it kind of as a continuum, and I think of athletes, you know, from the young all the way to the old. And so we're just going to kind of run through just a common sense approach to shoulders and go from there. So athletes, as I see them, come in all forms and sizes, from our little 4-year-olds that are playing soccer to our 80-year-olds that are still running marathons. And I like to think of the patients when they come in terms of that, and try to get them back to their level of function, okay? So athletes also come in with their own agendas, especially at the high school and college level. Concussions really play into that and trying to get back into play. And they also come with parents that have agendas as well. And so what we're going to do is run through the shoulder and talk about sort of what to do now, what the next step is, when to image, and when to refer. So I break this down basically by chief complaint, and we're going to go from kind of dislocations to biceps pathology to rotator cuff pathology. So the first one is sort of guy comes in, gal comes in, doc, my shoulder popped out. Sometimes it's happened multiple times, sometimes it's the first time. Then we're going to talk about the person who pulled their shoulder, and then the person who can't lift, okay? So the dislocator, typically this is your younger athlete. They're sent in from the field or the ER, and sometimes you're doing a history and physical, and they say, oh yeah, my shoulder just pops out. And you kind of have to work yourself back to figure out, is this a traumatic injury? Is this a non-traumatic injury? And do they just have, congenital laxity? So history is probably the most essential part to diagnosing shoulder pathology in the young athlete. And you need to know how it happened, where it happened, because that's going to be important in terms of trying to figure out what their function is and getting them back to their functional state. What position was the arm in? Because that tells you what position it might be unstable in going forward. And what did it take to pop it back in? Was it something that just popped back in on its own? Did somebody have to pop it back in on the field? Or did they have to go to the ER and get sedation to have it pop back in? And then what direction did it pop out? And then sometimes you're examining and you go, oh, this isn't right. So what do? I've had people walk into my clinic literally with the shoulder still out. And it's, a little bit frustrating because somebody should have picked this up along the lines, but sometimes it happens. And so what do? Well, first thing, you got to get the patient to relax. And without an IV, without sedation, the best thing to do is lay them on their stomach, get them comfortable, and get their arm in a traction position, okay? And that's going to take a little bit of time. And then you just gradually let the weight of the arm and a little bit of traction, pop it back in. I've done this on multiple occasions, both on the field and in the clinic, and it works quite well. So it's a nice thing to have in your tool bag. So again, with the history, you want to know if this has happened before, especially with multiple dislocators. It's important to find out, what are the activities that are causing this, and what's the amount of effort it takes to pop it out. Have they had surgery? Have they had physical therapy? What's been done, before they're presenting to you to have treated this? And does it come out in their sleep? And I've actually had a number of people that have fixed their shoulder that one of their biggest complaints was, doc, my shoulder pops out in my sleep. That's a really worrisome complaint, because it means that the likelihood of them, progressing through physical therapy and non-operative treatment and having success is pretty low. So the physical exam is also important, but it's difficult to do acutely and tends to be better as time progresses. You need to tell them that the exam is going to be uncomfortable, but it's not designed to produce pain. And the big thing is trying to figure out, what position is this going to be unstable in, and how unstable is it? And if they do pop it out while they're in your office and you're trying to examine them, you can go back to the Stimson maneuver and try and pop it back in. So they'll always come to you in a sling unless they're in the ED. And I also caution you to make sure you fully examine them, remove their shirt. It's a really good way of figuring out, is this still dislocated? And also finding other things. I've actually found skin cancers on people just by removing their shirt and examining the shoulder. So it's important. So you obviously need to inspect it. Is it still dislocated? You want to see where they're tender. It's important to note that they're going to have some bruising, and just tell them that it's not, don't freak out about it. It's normal to have this bruising. It happens with a dislocation. You want to check the range of motion and their strength, especially in older patients. Strength is important because the dislocation can be associated with a rotator cuff tear. You want to gently check their stability. And so I start out with their arm abducted at about 45 degrees and gently externally rotate. Okay? You want to document, does it dislocate at 45 degrees, 60 degrees, or can they get it to 90 or even beyond 90? And you check that both at 45 degrees and then at full abduction. If they're starting to feel apprehension just down at their side at 45 degrees, it's a worrisome sign that their shoulder is very unstable. And then the relocation test. So as you're doing these provocative maneuvers, you can also push back or lever back on the humeral head. And a lot of times they'll say, oh, that feels so much better. It doesn't feel like you're popping my shoulder out, doc. Thanks. So you need to remember that this is a continuum from subluxation to dislocations that pop back in on their own to ones that require sedations to the multiple dislocator, either because they've got congenital laxity or because they keep going back to the thing that dislocates their shoulder and not having it fixed, and then the ones that have dislocations with minimal effort. So what do you do now with them? You've got somebody who's dislocated their shoulder, where do we progress from here? If it's not done already, I always get x-rays, okay? If they've got a bony injury, a Hill-Sachs lesion, a bony Bankart lesion, or a glenoid fracture, that's something that you probably want to refer to the orthopedist to have them deal with. I always get AP, scapular Y, and axillary views. It's my standard 3 views for the shoulder. And it's important because it shows you where the humeral head is located relative to the glenoid. And for almost all these patients, I order an MRI because it's very, very rare that I see a dislocated shoulder that doesn't have some concomitant pathology of the labrum or the stabilizing structures. So I typically order a contrast-enhanced MRI and a closed magnet. So what do you do now? Well, initially you're going to immobilize them, and there's a lot of controversy as to how long you immobilize them. Do they get stiff? You immobilize them too long. I tell you about 3 weeks, and that's what the other orthopedists that I've worked with have done and what's come out of my training. And then there's controversy about what position. Do you keep them internally rotated? Do you externally rotate them? There's some data to suggest that if you keep them externally rotated, their risk of recurrence is lower. The problem is it's very difficult to keep, especially a 16-year-old, in a position of external rotation for 3 weeks. Good luck. So I always get these kids and young adults into physical therapy. While they're in their sling, they can start doing some pendulum exercises and some isometric strengthening. And as you get them out of their sling, they're going to work on rotator cuff strengthening and stabilization to help prevent the shoulder from dislocating again. And the physical therapist can be very instrumental in trying to figure out, can I get this person back to play? Because they're going to run them through exercises to see where they're still producing provocative maneuvers with their normal play. So if they can't get their shoulder or their arm into a position of function that they're going to need for play, they're probably not ready to go back. And the physical therapist is great for helping determine that. So when to refer? Anytime you feel uncomfortable, I'm happy to see these patients because this is sort of my bread and butter. If the MRI shows a labral or capsular tear, I think that's a reasonable reason to refer. If they've got any sort of bony injury, I think that's a really good indication to refer. And if they're not improving with physical therapy or they're unable to return to their previous activity level. And then if it's a multiple dislocator, it may mean that they're not going to get better with just conservative care. And 60% of patients that have had one dislocation will have a second dislocation between the ages of 21 and 30. So we're moving on from sort of the younger athletes to a little bit older athletes. And these are the people that are coming in and say, hey doc, I pulled my shoulder. And this can happen, at the gym. It can happen, horsing around playing basketball. It can happen starting a mower, starting a snowblower. We don't have that too much here unless you're up in Tahoe, but you can get this in the Midwest a lot. And they're going to have this history that they felt like they pulled their shoulder. They felt like they popped something in their shoulder, and now it clicks and pops when they're moving it. You may get a history that they're trying to throw a punch and missed and had a traction injury, but it's typically that traction injury that's pulling on the biceps, that's pulling on the labrum that creates the injury. Same kind of history questions I go through with all my shoulder patients. And these are typically throwers, people that had a fall or some sort of traction injury again. So exams fairly similar. For all these patients, I do check their stability because that tear to the labrum can extend down the front of the shoulder and create some amount of instability. They'll have pain with palpation directly over the biceps, and they'll have pain with both Speeds and Jurgensen's tests, and I'll show you those in a minute. And then compression and circumduction will often elicit a click or pain. So Speeds test on the right there is with the arm extended, and you're resisting supination or activating the biceps. Jurgensen's is similar with the arm at the side. Again, you're resisting supination to activate the biceps tendon. I find Jurgensen's test is a little bit more sensitive because you're not activating the rotator cuff nearly as much, so it tends to not have cross pain signals. So for imaging, x-rays really aren't helpful, although a lot of insurance companies for some reason want you to get x-rays before you order an MRI. But MRI is the method of choice for imaging this. And I always order these with interarticular contrast with an abduction external rotation view, and it's important to order it with that ABER view to really adequately image the biceps tendon. That being said, on non-contrast MRIs that we get for rotator cuffs, for other injuries, it's probably the most overcalled diagnosis that I see. And I get a lot of patients in that have had a diagnosis on an MRI of a possible slap tear, and they usually come as possible slap tears, but their history and exam don't really bear out. So that's important to know. So if their history, exam, and the MRI all match up, send them on. There's not much that's going to, in the non-operative realm, if they're not getting better with physical therapy, the likelihood is that this is something that's going to need surgical correction. But I think it's perfectly acceptable to start with physical therapy, and it's what I do for almost all my patients that come in with a possible slap tear, because a certain percentage of them will get better. And they work on range of motion, strengthening, scapular stabilization, capsular stretching. And if they're not improving after 6 weeks and I haven't gotten an MRI, that's when I'll image. So if you send it to an orthopedist, what are they going to do with it? Well, they might inject it for diagnostic purposes. I don't tend to inject biceps tendons with cortisone therapeutically unless they're a patient that really wouldn't tolerate surgical intervention. And on the surgery side, for these, I typically do a biceps tenodesis. So I actually clip off the biceps tendon where it attaches to the labrum and transfer it up to the humeral head. So the next athlete you're going to see moving on in age typically is the guy or gal that comes in and says, look, I can't lift my shoulder, I can't sleep on my shoulder without pain. And the history for this is typically longer. It's less of an acute type injury scenario. And things they'll tell you is that they can't lift their shoulder, it hurts to sleep on it, they can't lift it without any pain, they can't get stuff out of the cupboard without having any pain, and the pain typically will radiate down the lateral side of the shoulder. Same history, you think overhead lifter, thrower, and I see a lot of carpenters and especially drywall people come in with these chronic overhead use injuries. So the exam's similar, checking their range of motion, rotator cuff strength, their impingement test, checking their AC joint, neck, and scapula. And it's important to check the neck and the scapula to see if there's any concomitant pathology that's contributing to their overall shoulder pain. The pain, when you're palpating, will be typically over the anterior and lateral aspect of the shoulder. If you extend the arm, you'll expose the humeral head to the front, and you can actually directly palpate the supraspinatus tendon, and it'll be painful. They'll typically have pain with impingement testing, and they'll have pain with rotator cuff strength testing. You want to check the supraspinatus, the subscapularis, and the infraspinatus in terms of their strength and pain with those tests. They'll typically have pain with compression, adduction, and forward elevation. I also do Speeds and Yerkeson's tests because we do see concomitant biceps pathology with this. For the subscapularis, I like the lift-off test. It's whether or not they can lift off the back of their belt line with the hand. Typically, they'll also have pain with the bear hug test, where they reach across the other shoulder and squeeze. And then I call it the hand clap test, because I tell people to push their hands together and nobody gets it. So I say clap your hands, and that seems to elicit the appropriate response. Supraspinatus testing, again, adduction, thumb down, thumb up. That will get both sides of the supraspinatus and actually into the anterior infraspinatus. And then the infraspinatus is external rotation with the elbow tucked to the side, I find to be the most relevant test. So you have to understand it's a continuum of pathology, just like we talked with the dislocator, the subluxator. This progresses from tendinosis and tendinitis through to partial thickness tears and then full thickness rotator cuff tears. And I kind of break it down to simplify things into tendinitis is typically pain, but no weakness. They'll always have an impingement sign. Partial thickness tears, typically they'll have pain with weakness, and often these are more painful, I find, than full thickness rotator cuff tears. And I've been actually really surprised over the years how many of my partial thickness rotator cuff tear patients actually have more pain than my full thickness rotator cuff patients. And then the full thickness patients will typically have more weakness than pain, and they may have a drop arm test, positive drop arm test, where they can't hold their arm up when it's really bad. So what to do next? If they've got pain and no weakness, I typically send them to physical therapy. If they have pain and weakness, I'll start them off in physical therapy, and if they're making adequate progress, great. If they're not, I'll image it with an MRI. But they really need to be engaged in the physical therapy, and they need to be doing it at home, and you need to check in with them that they're actually doing what the physical therapist has outlined for them. And then the weakness with pain. If they've got substantial weakness, I always skip to the MRI, because the likelihood is that they have a full thickness rotator cuff tear, and the longer I wait, the more it retracts, the more difficult it's going to be to fix. So when to refer? So if you don't fix these, you got to refer them to somebody. And I always tell my referring docs, if they've got a history and physical exam with weakness, and if they've got an MRI, if they don't have an MRI, send them to me, and we'll go from there. Some docs will want an MRI before you refer them. If they've got a history and physical exam with a rotator cuff tear on MRI, please send them over. The longer they wait, the more they retract, and the more difficult they are to fix, and it can become a chronic problem where they actually end up having to have a replacement. If they've got a history and physical consistent with the rotator cuff tear, and they've had failure of adequate physical therapy, I'm always happy to see them. I always get this question, well, should I inject? And I think, it kind of goes back to risks, benefits, and alternatives. And there is some data that multiple cortisone injections and even a single cortisone injection can weaken the structure of the rotator cuff. So what I do in my own practice is I use these for the following situations. If they've got refractory pain and they've got a known rotator cuff tear, but I'm unable to do any surgery on them for medical reasons, I'll typically do a cortisone injection. If they have refractory pain with tendinitis on the MRI, I'll try a cortisone injection to allow them to get into physical therapy and work with the physical therapist in a relatively pain-free manner. If they're unable to do any physical therapy due to pain and they've got no obvious sign of a rotator cuff tear, I'll typically do it then. And I'll do it with lidocaine alone if I'm trying to figure out, is this a rotator cuff tear or not? These are injections that you should be able to do as a primary care physician, and I'm more than happy to help teach anybody that wants to learn and come to your office or have you in my clinic to help learn this, because I think this is something that every primary care physician should be able to do. They're easy, they're simple, and you can bill for them. So what I do with these when you send them to me, first of all, I tell them to quit smoking. It's very difficult to get a rotator cuff tear to heal, either a partial thickness tear non-operatively or a full thickness or partial thickness tear operatively to heal while they're still smoking. If they've got tendonitis, I'll typically start them with physical therapy, anti-inflammatories, and ice, plus or minus a cortisone injection. Partial thickness rotator cuff tears, initially I start out with physical therapy, anti-inflammatories, and ice, and if they've got no resolution with adequate physical therapy after 6 to 12 weeks, and an MRI shows a partial thickness tear, then I'll talk to them about surgery. And then full thickness rotator cuff tears, if they have significant pain and disability from it, we'll talk about surgery if they've got good motion and they're medically sound. So where do I see these go wrong? Typically, if I've got a patient that's been in a sling for 6 weeks, they get stiff, and then it becomes a battle between relieving their stiffness and fixing the rotator cuff tear. If they've had multiple injections in the setting of a partial thickness tear, I think that tends to lead down the road towards a full thickness tear. Patients that have been on narcotics for a long period of time tend to be problematic in this scenario. And if they've had inadequate engagement with physical therapy, because the likelihood is if they're not willing to do the physical therapy before, it's going to be difficult to get them to do physical therapy after surgery. And these are typically the people that want a quick fix. And with rotator cuff pathology, a lot of times it's not a quick fix. And then weakness that just doesn't get imaged, and we've got a retracted rotator cuff tear to deal with. So in summary, you've got your young athletes with a traumatic injury. Typically, these are your dislocators with labral pathology and instability. Youthful athletes with traumatic injuries or atraumatic biceps pain. Typically, these are slap tears or biceps tendon injuries. And then the aging athlete with or without trauma and pain and or weakness typically leads you down the road to the rotator cuff tear. Questions? I'm also happy to take any questions, again, back on concussions from the sports medicine side. I've had quite a bit of experience both coaching and on field as the team doc for multiple levels. And actually, even at my U10 son's age, we've had 3 concussions this year alone. So.
Hello. There we go. Thank you for the wonderful presentation. In primary care, I get involved with a lot of sports and non-sports injuries, and I thank you for that comment on narcotics. It does muddy the water. But the question I have is for the hyperlax patients, hyperelasticity or variants of Ehlers-Danlos that we see probably more frequently than we think. But I just had a gentleman the other day that dislocated the anterior shoulder dislocation, 3rd time. No history of surgery, popped it back in himself. And I was examining him, I realized how super lax his skin was. Pulled his thumb all the way back to his forearm, didn't flinch. What do you do with these patients?
Did he have an injury?
Yes, but not a serious injury. He was surfing, and he fell off the surfboard, hit the water, and at that, just hitting the water with his arm, popped the shoulder out.
Yeah. These are difficult patients. I always start them in physical therapy to see, can we recreate the stability of the shoulder by improving the rotator cuff strength. Okay, so I think that's, without adequate rotator cuff strength, the likelihood is, that they're not going to get better either way. Surgically, they become difficult because the tissue tends to stretch out, and so then unless they have a defined pathology, either of the glenoid or of the labrum that can be fixed, it becomes difficult because taking tucks in the capsule, they tend to stretch out, and then it becomes a long discussion over are these activities you should engage in? Are there ways to avoid you dislocating your shoulder? Is it reasonable for you to do this given your medical history? If they had critical aortic stenosis, you wouldn't send them back out on the surfboard, right? You would counsel them against that. So sometimes it's that hard talk that you have to schedule them for, to say this may not be appropriate for you, or you may have to live with the consequences of what you want to do.
Okay. How long do you want to have a break for?
Thank you.